When placing topical for an ASA injection, you're going to use the cotton tip applicator, stay parallel to the long axis of the canine, and place it in the height of the mucobuccal fold. For the ASA injection, the goal is to keep the barrel parallel to the long axis of the tooth. You're going to insert into the height of the mucobuccal fold 3 to 4 millimeters and deposit at least half a carpule of anesthetic.
MSc.
An MSA injection will numb the mesial buccal root of the first molar and the 2 premolars. To give this injection, insert at the height of the mucobuccal fold over the second premolar. If the frenum is in the way, you can choose either side to insert. Insert about 4 to 5 millimeters, aspirate, and deposit about 1/4 of the carpule to prepare for periodontal debridement procedures.
PSA.
The post-traumatic process. The needle puncture point is in the height of the vestibule, immediately behind the zygomatic process. It is normally situated between the distal buccal root of the second molar and the mesial buccal root of the third molar. The zygomatic process is easily identified by gentle palpation buccal to the first molar. As the probe is moved posteriorly, it falls behind the process, indicating the insertion site. The distal boundary of the zygomatic process is palpated. The needle is carefully advanced to the insertion point and oriented medially as well as posteriorly and superiorly. For the average adult, the needle axis should be at an angle of 45 degrees to all 3 planes. The needle is slowly advanced to a depth of 15 millimeters. After careful aspiration, 1/2 to 1 cartridge of anesthetic solution, or about 1 to 1.8 milliliters, is slowly injected. With the proximity of the posterior superior alveolar artery and pterygoid venous plexus, hematoma formation is a potential complication. This risk, quite low with proper technique, is increased if the needle is inserted too far laterally, and especially if it is redirected while embedded in tissue. Both errors tend to occur when the operator allows the cheek to torque the syringe medially during injection. If the insertion point is too anterior or too close to the alveolar process, or if the angulation is too vertical or too medial, premature contact with bone will occur. In these situations, the needle should be withdrawn and correctly repositioned for a new, straight insertion.
Nasopalatine.
This is the nasopalatine nerve block. The nerves are the nasopalatine nerve bilaterally. Areas anesthetized are the anterior portion of the hard palate, the soft and hard tissues, from the mesial of the right first premolar to the mesial of the left first premolar. The needle gauge in length is a 25 or 27 short. The patient position is supine, mouth opened wide, neck extended, head turned to left or right for improved visibility. The operator position is 9 or 10 o'clock, facing the same direction as the patient. The landmarks are the central incisors and the incisive papillae. The target area is the incisive foramen located beneath the incisive papillae. The syringe position, the needle is approached at the injection site at a 45-degree angle towards the incisive papilla. The palatal mucosa lateral to the incisive papilla. The bevel orientation is against the palatal soft tissues. Pressure anesthesia, yes, before and during the injection. The depth of insertion is about 5 millimeters. Osseous contact, yes.
Contact?
Aspiration potential is less than 1%.
Aspiration negative?
And the amount of solution is 0.45 millimeters or 1/4 of the cartridge over 15 to 30 seconds.
Greater palatine.
palatine nerve block provides anesthesia to the posterior portion of the hard palate and its overlying soft tissues, anteriorly as far as the first premolar and medially to the midline. Position patient supine if possible. Have the patient open wide and extend their neck with their chin towards the ceiling. Place cotton swab and apply moderate pressure at the greater palatine foramen, which is located just distal of the second maxillary molar, where the teeth transition to the roof of the palate. You will note the blanching of the soft tissue with the pressure applied by the cotton swab. Direct the syringe into the mouth from the opposite side with the needle approaching the injection site at a right angle. Then place the bevel of the needle against the previously blanched soft tissue at the injection site. Penetrate the blanched site approximately 3 millimeters. Aspirate syringe. If negative, slowly deposit 1/4 of a cartridge over 30 seconds. You should feel considerable resistance in the syringe. Withdraw the syringe, cap the needle. Wait 2 to 3 minutes for soft tissue anesthesia to set in.
Hi guys, this is Dr. Question is we will get to know how when we finish injecting the solution for 1 minute and 2 minutes, this doesn't mean these need only we need only 0.9 to 1.2 ml. Be a difficulty. You guys will help me contact this of the tooth, and now the needle is over the gentle infraorbital foramen. So this is the infraorbital, and this will be painful for the patient. And in this nerve block, we want to direct the local anesthetic solution towards the infraorbital foramen. So that's why bevel should be facing bone. Patient should be seated first premolar. We get the shortest route to this target area. So that's the reason we insert the needle over the first premolar. The landmarks here, which should be palpated, fold over the first premolar. You may wonder we need only 0. So the tooth to achieve hemo block, we use a 27 gauge long needle. The area of needle insertion is the height of the mucobuccal fold over the first premolar. You may wonder why we can't go over any other tooth. Actually, we can reach our target area, which is the infraorbital foramen, from any tooth from the second premolar to the central incisor. But if we go from the first premolar, we get the shortest route to this target area. So that's the reason we insert the needle over the first premolar. The landmarks here, which should be palpated, are the mucobuccal fold, infraorbital notch, and the infraorbital foramen. The bevel of the needle should be towards bone, as with every block that we have seen so far. The reason for this is the same. When the bevel faces bone, it glides over the bone when the needle contacts bone. If bevel faces away from the bone, the sharp point of the needle can tear the periosteum, and this will be painful for the patient. And in this nerve block, we want to direct the local anesthetic solution towards the infraorbital foramen. So that's why bevel should be facing bone. Patient should be seated in a supine position with the neck extended slightly. Next, we should prepare the tissues at the needle insertion site. So the tissues are dried with a sterile gauze, and a topical antiseptic and a topical anesthetic is applied. The topical anesthetic should be kept for a minimum of 1 minute. Now we locate the infraorbital foramen. So this is the infraorbital foramen, and we can locate it by palpating certain landmarks. First, we palpate the infraorbital notch. Then, while applying gentle pressure to the tissues, we move the finger downwards. Immediately inferior to this notch, we will feel an outward bulge. This is the lower border of the orbit and the roof of the infraorbital foramen. As we move the finger downwards, we will feel a concavity or a depression. This is the infraorbital foramen. We have to be very gentle while palpating this area, as the patient will feel a little bit of soreness because the infraorbital nerve is getting pressed against the bone. Now that we have found the foramen, we should keep the finger here or else mark the area over the skin. Now we should retract the lip and pull the tissues to make it taut. For retracting, we can use our own finger or a mouth mirror. Using the mirror is better as it will protect us from needle stick injury. Now we insert the needle into the height of the mucobuccal fold over the first premolar with the bevel of the needle facing bone. The needle should be parallel to the long axis of the tooth, otherwise we might contact bone too soon. So the syringe is oriented towards the infraorbital foramen. The needle is parallel to the long axis of the tooth, and now the needle is advanced slowly until bone is contacted. So keep in mind that we don't have to direct the needle towards the bone. If we do that, we might contact bone before we reach the infraorbital foramen. And this will be just like local infiltration over the first premolar. This will result in failure of the nerve block. So always keep the needle straight towards the infraorbital foramen and parallel to the first premolar. For maximum comfort of the patient, it's good to deposit a few drops of local anesthetic as the needle passes through the soft tissues. The depth of needle penetration is 16 millimeters. So this means that when about half of the needle is in the tissues, this depth is achieved, and at this depth, usually we should contact bone. When I say that we contact bone, we are contacting the upper rim of the infraorbital foramen. This contact with the bone at the roof of the infraorbital foramen prevents overinsertion and puncture of the orbit. Depth of penetration can be different for different patients. Some patients have a deep mucobuccal fold and some can have a low infraorbital foramen. So these patients will require less tissue penetration. So to decide how much depth we need to reach the infraorbital foramen, we can place one finger on the infraorbital foramen and another finger intraorally on the injection site in the mucobuccal fold. And we can estimate the distance between these two fingers, and in this way, we will get to know how much depth of penetration we will need. Before injecting the solution, we should aspirate in two planes and slowly deposit 0.9 to 1.2 ml of solution over 30 to 40 seconds. We will see little or no swelling as we deposit the solution because the solution is directed towards the foramen. The reason we keep a finger over the foramen while injecting is that if the needle tip is in correct position, we will be able to feel the anesthetic solution as we inject. When we finish injecting the solution, because of the volume of the solution, now we won't be able to feel the foramen. Another important reason of placing the finger here is that when we keep firm pressure over the injection site, both during the injection and for 1 minute after the injection, it increases the diffusion of the local anesthetic solution into the infraorbital foramen. We should keep the finger pressure over the injection site for a minimum of 1 minute after the injection, and 2 minutes is even more preferable. The finger over this area will also help us to direct the needle towards the foramen. When the needle is in correct position, the needle should not be palpable. If we can feel the needle, then it means that it is too superficial.